This is Ian Bodford.
And Liang Liu.
And welcome back to the Clinical Correlation.
Today's case is...
This is a 75-year-old man with a history of hypertension, diabetes, and atrial fibrillation who was brought in by his family after a fall at home. The fall was mechanical, but he did strike his head on the ground. He did not lose consciousness and has remained awake. However, he has become progressively more and more confused.
Family reports that he is usually very active and able to care for himself. On chart review, you note that he is taking metoprolol, metformin, and warfarin.
His vitals are essentially unremarkable.
Physical exam reveals a well-appearing elderly male with a large soft tissue hematoma and contusion to the right parietal region. No active bleeding is seen. He is alert but only oriented to his name. The rest of his neurologic exam is normal.
An altered mental status workup is started, which includes labs and a STAT CT head.
His CT returns with a large right-sided subdural hematoma, and his INR returns at 3.5. Aside from calling neurosurgery, what is your next move?
No discussion of anticoagulants would be complete without the coagulation cascade. Although not important to memorize, it is significant to know where each anticoagulant acts.
Warfarin, the most common anticoagulant, inhibits the vitamin K-dependent synthesis of clotting factors 2, 7, 9, and 10, as well as the regulatory factors protein C, protein S, and protein Z.
Heparin and low molecular weight heparin bind to the enzyme inhibitor antithrombin 3, causing a conformational change that results in its activation. The activated antithrombin then inactivates thrombin, factor 10A, and other proteases.
10A inhibitors act directly upon factor 10 in the coagulation cascade without using antithrombin as a mediator. And 2A inhibitors, also known as thrombin inhibitors, act by directly inhibiting the enzyme thrombin.
Although the most common of the anticoagulants, warfarin has several shortcomings. Many commonly used medications interact with warfarin. It also interacts with several types of food, specifically those with large amounts of vitamin K1. Its activity has to be monitored by blood testing for the International Normalized Ratio, or INR.
The decision to reverse warfarin depends on the patient and the presentation.
Firstly, is there evidence of active bleeding? If so, control the hemorrhage and correct the coagulopathy.
Other factors to consider include how elevated the INR is, what the therapeutic indication for anticoagulation was, and what other risk factors the patient has for bleeding.
Treatment ranges from holding the warfarin to giving vitamin K, fresh frozen plasma, or 4-factor prothrombin complex concentrate.
Vitamin K should be given via IV or PO route, with PO being the safer and more reliable reversal, while IV should be reserved for rapid reversal and serious bleeding only.
4-factor PCC contains factors 2, 7, 9, and 10, as well as protein C and S. These are all of the factors that are inhibited by warfarin.
Fortunately, the American College of Chest Physicians, American Heart Association, and the American College of Cardiology have developed evidence-based medicine guidelines for the reversal of warfarin with FFP, PCC, and/or vitamin K. These recommendations are summarized here.
Generally speaking, in the case of a serious or life-threatening bleed, warfarin should be held and vitamin K and FFP or PCC should be used for emergent reversal.
2 units of FFP should be given for low to moderate risk bleeding, and 4 units for high risk or active bleeding. INR should be rechecked 1 hour after administration of FFP.
PCC should be administered to patients on warfarin with INR greater than 2 and evidence of intracranial hemorrhage on CT head. Dosing is weight-based and should be given via IV push over 5 minutes. INR can then be rechecked 30 minutes after administration.
Dosing of vitamin K should be based on INR and risk of bleeding. Additional consideration for lower doses are important to consider for those who are at high risk for thrombosis, as in the case of patients with prosthetic heart valves.
If no bleed is present, management of supratherapeutic INR is more conservative, either lowering the dose or skipping 1 to 2 doses until INR is therapeutic.
Heparin and low molecular weight heparin are most commonly used in the inpatient setting. Low molecular weight heparin can be used as a bridge to warfarin or in patients with contraindication for warfarin. Fragmin and Lovenox are 2 of the most common low molecular weight heparins currently available. If unsure, all the generic names of low molecular weight heparins end in heparin.
A serious side effect of heparin is heparin-induced thrombocytopenia and thrombosis. Multiple mechanisms contribute to the syndrome. In HIT type 1, there is an immune-mediated response resulting in platelet aggregation and thrombocytopenia, and in HIT type 2, there is an immune-mediated activation of platelets promoting thrombosis.
Protamine sulfate is the agent used for reversal of life-threatening bleed in a patient on heparin or low molecular weight heparins. It is a peptide that binds to the heparin or low molecular weight heparin molecule and forms a stable ion pair, deactivating the molecule.
Fortunately, there is a linear relationship between protamine dose and amount of heparin or low molecular weight heparin needing reversal.
1 milligram of protamine neutralizes 100 units of both fragment and IV heparin.
Keep in mind, however, that the half-life of heparin is relatively short and calculations of protamine dose need only take into account the previous couple of hours. If heparin was given subcutaneously, a slightly larger dose is needed.
In Lovenox, there is a 1-to-1 ratio of 1 milligram protamine for every 1 milligram Lovenox, if reversal is given less than 8 hours since the last dose. If the time frame is longer, the ratio is 1-to-2 of protamine to Lovenox.
A baseline anti-10A activity level should be obtained prior to administration of protamine for low molecular weight heparin so that this level can be followed while the patient is admitted. Factor Xa inhibitors are part of the novel oral anticoagulants, or NOACs. They're easy to recognize as all of the generic names contain an XA.
These newer oral anticoagulants have the benefit of established safety and efficacy. Additionally, they have the practicality of not requiring laboratory monitoring and less drug-drug interactions and less food-drug interactions.
However, there are newer agents that have not been time-tested. The evidence is limited to guide clinical management of patients on these agents.
Especially in the patient on one of these agents who then presents with a serious bleed or who require emergent surgery. These agents have quickly become more popular as the anticoagulant class of choice. Are there any guidelines on management of these patients?
Some studies have shown effectiveness of prothrombin complex concentrate and recombinant factor 7A and reversal of factor 10A inhibitors.
2 candidate reversal agents, andexanet alpha and sierraparin tag, are also in various stages of development with promising early studies. However, as it stands now, there is no antidote that has been FDA approved.
Direct thrombin inhibitors are also part of the NOACs. Thrombin is the common name for factor 2.
Heparinin is a direct thrombin inhibitor. Interestingly, heparinin is a peptide that is found in the saliva of leeches, which is what keeps blood from coagulating during their feeds.
Argatroban is used in DVT prophylaxis in those with a history of HIT. It is also approved for use in percutaneous coronary intervention. Bivalirudin is also used in PCI and in STEMIs. Pradaxa, or dabigatran, is an oral medication that can be used in stroke prophylaxis in those with atrial fibrillation or to treat DVTs or PEs in certain patient populations.
There is currently no way to detect levels of these medications in the blood or to check their effectiveness.
For argatroban and bivalirudin, options are extremely limited for reversal. The only option currently is to turn off the infusions of the medications.
In October 2015, idarucizumab, also known as Praxbind, a monoclonal antibody fragment that binds to dabigatran, received expedited approval from the FDA for use.
The dose is 5 grams IV. In the United States, a single dose is around $3,500. Additionally, dabigatran is 65% dialysable, so if a patient already has dialysis access, consider consulting nephrology for dialysis. To summarize, new oral anticoagulants are becoming more and more popular. Know these medications and how they work.
Reversal agents are available for many of the common anticoagulants. Know your options, whether it be holding the dose, giving vitamin K, PCC, FFP, protamine, or other novel solutions.
In a life-threatening bleed, don't be afraid to ask your hematologist and pharmacist for help. Also, in the case of Pradaxa, consider talking to nephrology for dialysis.
Don't forget your resuscitation skills. Apply pressure to bleeds and transfuse as necessary. So that's it for this case.
Send us your comments, suggestions, and cases to theclinicalcorrelation@gmail.com and follow me on Twitter @MDNotified.
And me @EMLU.
Thanks for listening.